Good morning, everyone. I'll be speaking on the management protocol after reduction of shoulder dislocation. This is regarding the primary dislocators. These are the areas which we'll be trying to address: when to do the check X-rays, period of immobilization, position of immobilization, rehab duration, return to activity of daily living, sports, and what are the factors which have already been covered. So starting with the anterior dislocations, X-ray studies have shown that many of the fractures, more than 1/3, are missed on the pre-reduction X-rays and are detected on post-reduction, which is why what we recommend is to do both the pre and post-reduction X-rays to confirm the reduction and to find out the injuries which may have occurred during reduction, and also check X-rays at the end of 3 weeks when you would begin your rehab protocol. Regarding the duration of immobilization, Hovelius studies 257 patients in which he divided into two groups: early mobilization versus those immobilized for 3 to 4 weeks. At 2-year follow-up, he saw that there was an equal rate of recurrence, and again, the less than 22 years age group showed almost 50% had redislocated. Patterson did a meta-analysis on the duration and found again no significant difference in the recurrence rates for those immobilized for 1 week or 3 weeks. So our recommendation is to immobilize for 1 to 3 weeks, and with the patient comfort levels, start with the initial pendulum or elbow ROM. Regarding the position of immobilization, again, now the controversies between external rotation versus internal rotation. Proponents of the external rotation say that when you put them in ER, the tension on the subscapularis puts the capsule and the labrum in close contact with the anterior glenoid. Itoye et al. Very recently has published this study of 198 patients with a 18-year follow-up, where he says that immobilization and external rotation reduces the risk of recurrence and the need for surgical intervention. This is the splint that he had recommended, where the arm is kept in adduction and 10 degrees of external rotation. Patterson and Shinagawa also conducted meta-analysis which showed that recurrence rates were lower with the arm in external rotation. However, a Cochrane review done in 2019 said that there was insufficient evidence to determine that immobilization and external rotation would provide any significant benefit over internal rotation. So our recommendation is, because the data is still emerging on the immobilization and external rotation position, further studies, I would say, are needed in our population specifically. We could continue immobilizing in internal rotation as it's more practical. And since there is no difference in the recurrence rate, especially in the high-risk group of the young patients, and possibly the lower compliance with that external rotation position. With the rehab protocol, Riccio described a 3-month rehab protocol where they used the Rose score of instability. They saw that there was a significant improvement from 44.5 at start to 79.8 at the 2-year mark. They reported no subluxation or discomfort during this rehab program. So we recommend a graded rehab program to be started after 3 weeks, where the focus would be on gradually improving the range of motion and on the strength of the periscapular muscles. And the rehab protocol should be for at least 3 months. Return to activity was studied by Aranan and Regan, where they studied 20 male patients for 36 months. They saw that return to unrestricted duty and sports was seen without redislocation in almost 75% of the patients, and they took average of 3 months to return to their activity. Similarly, with sports, Bus et al. Saw that athletes missed 10 days of sports, with 27 of 30 athletes returning to play within 2 to 3 weeks, although 37% of them did experience one instability episode at least. They saw that athletes wearing a brace reported an improved sense of stability. Dickens et al., again in NCAA football athletes, showed that 73% returned to sport within a 5-day period of the injury. 36% showed no recurrence, 30% recurred but could complete the season, and 33% recurred but could not complete the season. So our recommendations for the activity of daily living, as per the pain of the patient, also to avoid abduction, external rotation, and overhead activities. And concerning sport, where the player is in season, within 1 to 3 weeks is a reasonable time for them to return with or without a brace. The recurrence rate, though, has to be warned, is a little high. And for out of season, they could then directly opt for surgery. These are some of the risk factors. Age, as we know, younger age is at more propensity. Males more than females, overhead activity, contact sports players, And patients with significant bony defects of more than 20% of glenoid or Hill-Sachs lesion could probably end up with primarily surgery. Coming to posterior dislocation, again, Durald and Fogel recommended that close reduction be attempted when the dislocation is acute, that is within 3 weeks, and where the reverse Hill-Sachs is less than 20% of the articular surface. Robinson et al. In their study of 120 patients showed that almost 33% could be close reduced just by inline traction and gentle manipulation. The immobilization protocol was in a gunslinger brace, which was in neutral rotation, abduction, and flexion. The period of immobilization was for 4 weeks, and then they started a graded rehab program for 3 months. Most could return to general fitness training and non-contact sports at 12 weeks, and they recommended to avoid contact collision sport until 16 weeks after the injury. Recurrence was not so high, 19%, and the factors associated were, again, a younger age group, seizure disorders, and Hill-Sachs more than 1.5 centimeter cube. So our recommendations would be, again, to get check x-rays pre and post reduction and at 1 month before we start the rehab, immobilize in abduction 0 to 10 degrees of external rotation and flexion for around 4 weeks, a graded rehab program after that. Return to activity of daily living would be around 4 to 6 weeks, avoid internal rotation. Return to sport would be, again, non-contact sports 12 weeks, and for contact sports, post 16 weeks. Thank you.